Ever see someone bruise really easily, maybe? Like from just a tiny knock. Or perhaps you've seen a blood test result flagging something called low platelets.
Yeah, that can be worrying.
Definitely. And that's what we're digging into today. We're doing a deep dive into immune thrombocytopenia, usually just called ITP.
Right.
We've got a great set of revision notes to guide us, and the aim is really to get a clear picture of this condition, what it is, what's going on, why it matters.
Without getting bogged down in overly technical jargon.
Yeah.
Absolutely. We want to make it click, give you those aha moments.
Exactly. Think of this as your, express guide to understanding ITP essentials.
Sounds good. So what's the roadmap?
Okay, so we'll start with the definition, nail down what ITP actually is. Then we'll look into the causes, the why. Risk factors too, who's more likely to get it.
Makes sense.
Then we'll get into how it works in the body, the pathophysiology, and crucially, what else could it be? The differential diagnoses.
Always important.
Yep. Then who it affects the epidemiology, what it looks like clinically, how doctors investigate it, how it's managed.
Treatment options.
Right. And finally, the prognosis, what to expect, and any potential complications to be aware of. Ready to jump in?
Let's do it. So first things first, the definition. What exactly is ITP?
Okay, so ITP, immune thrombocytopenia. At its core, it's an autoimmune disorder. Now, autoimmune just means your own immune system.
The body's defense force.
Exactly. It mistakenly starts attacking your own healthy cells. In ITP, the target is platelets. And platelets are those tiny blood cells vital for clotting, right? They stop bleeding.
The first responders when you get a cut.
Precisely. And the thrombocytopenia part, that just means you have a low count of these platelets, fewer than normal circulating in your blood.
That's the essence of it. And you might still hear the older name, sometimes Idiopathic Thrombocytopenic Purpura. That word idiopathic is quite key.
Meaning unknown cause, right?
Exactly. And that's really significant for what we now call primary ITP. That's where there's no other identifiable condition causing the low platelets. It just happens.
Okay. So primary is the mystery type in a way.
You could say that. And it's important to distinguish it from secondary ITP. Secondary means the low platelets are, well, secondary to something else, another illness, maybe a medication reaction, that sort of thing.
Got it. Primary. No clear underlying cause. Secondary. Linked to something else. That's a really crucial difference.
Absolutely.
And you mentioned it's not quite the same for everyone.
No, definitely not. The severity, the symptoms, they can vary hugely from person to person. Some might barely notice it. Others might have significant bleeding issues.
Right. And it seems like there's been an effort to make things clearer. The notes mention definitions being standardized since 2009.
Yeah, that standardization helps everyone, doctors, researchers get on the same page. It leads to more consistent understanding and treatment approaches.
Makes sense. And there's a difference between how it presents in adults versus kids too, isn't there?
Often, yes. Adult onset ITP, it tends to creep up more gradually, insidiously, and it can often become chronic, meaning long-term.
Sort of lingers.
Yeah. Whereas childhood ITP frequently pops up after a viral infection like chickenpox or a cold, and interestingly, it quite often resolves on its own spontaneously.
Well, that's quite different. So adult, maybe slower, chronic, child, often post-infection, might clear up.
That's a good general summary, yeah.
Okay, we have a handle on the what. Now let's move to the why. What actually causes ITP, especially primary ITP?
Well, this loops back to that idiopathic idea for primary ITP. The honest answer is the exact trigger isn't known.
Still a bit of a puzzle then.
It is, but we understand the mechanism involves a malfunction in the immune system. For whatever reason, it misidentifies platelets as foreign invaders and launches an attack.
Like friendly fire almost.
Pretty much. The body's security system gets its targets wrong.
So primary ITP is an internal mix-up. But for secondary ITP, you said there are known triggers.
Correct. Secondary ITP is linked to an underlying cause. Our notes list quite a few possibilities. Other autoimmune conditions are one category.
Like lupus.
Exactly. Systemic lupus erythematosus, or SLE. Also antiphospholipid syndrome. Then there are certain viral infections, things like CMV, varicella zoster.
Chickenpox and shingles virus.
Right. And Hep C, HIV too. Even, interestingly, H. pylori infection, the bug linked to stomach ulcers.
Really? H. pylori?
Yep, it's been associated. Also, certain medications can trigger it. The notes just mention this as a category, but it's definitely something doctors look for. And finally, some blood cancers, lymphoproliferative disorder.
Okay, quite a list for secondary causes. Now, what about risk factors? Anything that makes someone more likely to develop ITP in the first place?
Yeah, the notes point to a few things. A recent viral infection seems to be a factor sometimes, specifically mentioning Epstein-Barr virus that causes glandular fever
Well, no.
and hepatitis C virus. Gender also seems to play a role, with ITP being generally more common in females, especially between 30 and 60.
Yeah, female gender. Anything else?
And potentially a family history. It suggests there might be some genetic predisposition, although it's not usually seen as a directly inherited disease.
So maybe a slight genetic nudge in some families.
Possibly. So, key risk factors, recent specific viruses, being female, maybe a family link.
Right, so we know the immune system is attacking platelets. How does this actually play out inside the body, the pathophysiology?
Okay, so the key event is the production of autoantibodies. Think of these as like faulty seek and destroy signals made by the immune system. They specifically stick onto the surface of the platelets.
Marking them for destruction.
Precisely. Once a platelet is coated with these autoantibodies, it becomes a target. And the main places this destruction happens are the spleen and, to some extent, the liver.
Ah, the spleen. I remember that being important.
Very important. Immune cells in the spleen and liver recognize these antibody-coated platelets and basically engulf and remove them from circulation. It's like Pac-Man munching up the marked platelets.
Okay, so the spleen and liver are cleaning up these marked platelets.
Exactly, but that's not the whole story. The immune attack can also interfere with the bone marrow.
Where platelets are made.
Correct. It can hamper the production of new platelets by affecting the megakaryocytes, the parent cells. So you might get decreased production and increased destruction.
Ah, a double whammy.
It can be, yeah. And the end result of all this, a lower platelet count thrombocytopenia, which, as we said, leads directly to that increased risk of bleeding.
Makes sense. Now, if someone comes in with low platelets, it's not automatically ITP, is it? You need to rule other things out.
Absolutely critical. That's the differential diagnosis. You have to eliminate the other suspects before landing on ITP.
So what kind of things are on that list of suspects?
Well, there are some serious conditions like thrombocytopenic purpura, TTP. That needs ruling out quickly. Drug-induced thrombocytopenia is a big one. Lots of medications can potentially cause low platelets.
Right, always check the meds list.
Definitely. Then there's hemolytic uremic syndrome, HUS. Other autoimmune disorders like lupus, which we mentioned as a secondary cause, also need consideration.
Okay, so other autoimmune conditions can mimic it too.
Yes. Also, conditions affecting the bone marrow itself, like aplastic anemia, where it just doesn't make enough blood cells, or the effects of toxins, like rare, excessive alcohol use, which can suppress the marrow.
Alcohol, right. What else?
Leukemia is on the list. Even von Willebrand's disease, though that's primarily a clotting factor issue, it can sometimes present confusingly. Cancer spreading to the bone marrow, and DIC, disseminated intravascular coagulation, a complex clotting problem.
Wow, that's quite a range. It really shows why you can't just assume it's ITP based on a low count alone.
Exactly. A thorough workup is essential.
Okay, let's shift gears slightly.
Sure.
Who actually gets ITP? What's the epidemiology look like, especially in the UK?
Right, UK focus. The notes estimate the incidence. So new cases each year in adults is around 3.3, up to maybe 4 or 5 cases per 100,000 people.
So not super common, but definitely recognized.
Definitely. And there was a UK study from 2011 looking at prevalence, how many people are living with it, that found about 50 cases per 100,000 adults over an 18-year period.
50 per 100,000 prevalence. Okay.
And as we touched on, it affects both children and adults. Overall, it hits both sexes, but there's that specific peak in women between the ages of, say, 30 and 60, where it's more common.
Right, the female predominance in middle age.
Yeah. So the takeaway is it's a known condition, maybe not rare, but not everyday common, and particularly seen in that female 30-60 age group.
Okay. So what does it actually look like when someone has ITP? What are the clinical signs and symptoms?
It can present in different ways, as we've said, but common things include easy bruising, sometimes quite noticeable bruising from minimal trauma, or even seemingly spontaneous bruises.
Bruising easily, got it.
Then there are petechiae. These are tiny pinpoint red or purple spots under the skin. Think like tiny little dots.
Like pricks almost.
Exactly. And then purpura, which are larger purple patches, more like bruises, but again, often appearing without obvious injury. So remember, P for petechiae, tiny pinpricks, and P for purpura, larger patches.
P for pinprick, P for patch. Nice mnemonic. Okay, what else?
Nosebleeds can be common. Bleeding gums, too, gingival bleeding. And for women, menorrhagia, which is excessively heavy menstrual periods, can be a really significant symptom.
Right, heavy periods. How do people usually find out they have it?
Sometimes it's completely incidental. They have a routine blood test for something else, and boom, low platelets show up.
An unexpected finding.
Yeah. Other times, it's the symptoms that bring them in. They notice the bruising, the petechiae, maybe those nosebleeds.
Okay, and how severe can the bleeding get? Is catastrophic bleeding common?
That's the major concern, of course. But thankfully, really severe bleeding, like intracranial hemorrhage bleeding inside the head, is actually quite rare in ITP. Possible, but rare.
That's reassuring. So the key diagnostic point is
It's finding that isolated thrombocytopenia, meaning only the platelet count is low. Other blood cells are usually normal, with a count typically below 100 times 10 to the 9 per liter. And crucially, after ruling out all those other potential causes we listed,
isolated low platelets, count below 100, other causes excluded. That's the diagnostic hallmark.
exactly.
So if ITP is suspected, what investigations get done?
The first step is usually the basics. A complete blood count, the CBC, that confirms the low platelet count and checks the other blood cell lines are normal.
Get the numbers.
Right. And a peripheral blood smear. That involves looking at a blood sample under the microscope to actually see the platelets, check their size and appearance, their morphology. Sometimes in ITP, the platelets you do see might look large.
So check the count and check how they look. Are other tests needed?
Sometimes, a bone marrow aspiration and biopsy might be done, especially if the diagnosis isn't clear-cut, or maybe in older patients, or if treatment isn't working. It helps assess platelet production looking at those megakaryocytes we mentioned and rules out other marrow problems.
But not always necessary for a typical case.
Not always in younger adults with typical features, no. There are also tests for antiplatelet antibodies, those autoantibodies we talked about, but their sensitivity and specificity aren't perfect. So a negative test doesn't rule ITP out, and they're not always needed for diagnosis.
Okay, so they exist but aren't the definitive diagnostic test.
Pretty much. And really important as part of ruling out secondary causes is screening for infections like HIV and hepatitis C.
Essential checks.
Absolutely. So the whole diagnostic process is really a combination of the patient's history, the physical exam findings, that CBC showing isolated low platelets, the blood smear, and very importantly, ruling out everything else it could be.
Right, putting all the pieces together. Okay, diagnosis done. What about management? How is ITP treated?
Well, the first thing is treatment really depends on the severity. It's guided by the platelet count and, crucially, whether the patient has any bleeding symptoms.
So not everyone gets treatment straight away.
No. If someone is asymptomatic, no bleeding, and their platelet count isn't dangerously low, maybe above, say, 20 or 30, then observation might be perfectly appropriate, just monitoring things closely.
A watch and wait approach.
Exactly. But if the count is lower, or if there is bleeding, then treatment is usually needed. First-line therapy often involves corticosteroids.
Steroids, okay. How do they help?
They work by suppressing the immune system, aiming to reduce that destruction of platelets. Think C for corticosteroids as a common first step.
C for corticosteroids.
Yeah.
Got it. What else is used early on?
Intravenous immunoglobulin, or IVEA, is another option. It can often give a fairly rapid, though usually temporary, boost to the platelet count. Useful if you need to raise the count quickly, perhaps before a procedure. A quick fix, sometimes.
Sort of, yeah. For
Yeah.
cases that don't respond well or become chronic, then you move on to other things. Immunomodulatory drugs might be considered.
And what about splenectomy? Removing the spleen. You mentioned the spleen is key in destroying platelets. It is. And splenectomy used to be a much more common treatment. It can be very effective because you're removing that main site of destruction, but it's major surgery, carries risks like infection.
Right. Losing the spleen has consequences.
It does. So it's generally reserved now for cases resistant to medical therapies, and it's less common overall because we have newer options.
Like what? What are the newer options?
Well, there are the thrombopoietin receptor agonists, or TPORAs, drugs like romiplastim and eltrombopag. These actually work differently. They stimulate the bone marrow to produce more platelets.
Boosting production instead of just stopping destruction.
Exactly. Think T's for TPO agonists, telling the bone marrow to produce more platelets. These are typically used for refractory or difficult-to-treat cases.
T for telling the marrow. Nice. Any others?
Rituximab is another option, often used in refractory cases. It targets specific immune cells involved in the antibody production.
Okay, so a range of medical options now. What about general advice?
Yeah, general measures are important too. Things like stopping any medications that might affect platelet function if possible, good blood pressure control, managing heavy periods in women, and common sense things like avoiding activities with a high risk of trauma or injury.
Makes sense. Minimize bleeding risks.
Exactly. And just to recap those later options, if first-line treatments like steroids or IVI aren't enough, then splenectomy, those TPO agonists, rituximab, or other immunosuppressants are considered second line. But the key is,
It's tailored to the individual.
absolutely, treatment is very much personalized based on the patient's count, symptoms, lifestyle, and overall health.
Good to know. So what's the long-term outlook? The prognosis?
It really varies. As we said, in kids, acute ITP often just resolves on its own, which is great.
A good outcome there, usually.
Yes. In adults, though, it's more likely to become chronic or recurrent. It might require ongoing management. But, and this is important, even when it's chronic or difficult to treat, the overall prognosis for adults with ITP is generally considered good.
So even if it doesn't go away completely, people generally do well.
Yes, most people can live pretty normal lives with appropriate management. Regular monitoring, checkups, adjusting treatment as needed, these are key to keeping the platelet count at a safe level and optimizing outcomes.
That's reassuring. Finally, are there any particular complications to be aware of with ITP?
The main one, stemming directly from the low platelets, is the increased risk of bleeding. While most bleeding is minor bruises, maybe gum bleeding, there is that small risk of serious bleeds, like into the brain or gut. Rare, but possible.
The bleeding risk is number one. Anything else?
The notes mention a very rare possibility of ITP over time, transforming into other bone marrow conditions like myelodysplastic syndrome, MDS, or even acute myeloid leukemia, AML, but again, this is very uncommon.
Okay, very rare transformation risk.
And the other thing to consider is side effects from the treatments themselves. If you're on long-term steroids or other immunosuppressants, there's an increased risk of infections, for example.
Right, the treatment can have its own complication.
Exactly. It's always a balance between managing the ITP and managing potential treatment side effects. Requires careful monitoring and discussion.
Makes total sense.
Yeah.
Okay, let's try and summarize the key takeaways from our deep dive.
Right. So ITP is autoimmune. The body attacks its own platelets. This leads to a low platelet count, thrombocytopenia, and that increases bleeding risk.
Primary ITP cause unknown. Secondary ITP linked to other things like infections, drugs, or other autoimmune diseases.
Symptoms vary a lot, from none to significant bleeding, but severe bleeds are rare. Diagnosis involves finding isolated low platelets and ruling out many other conditions.
Management depends on severity, can range from just watching and waiting to medications like steroids, IVIG, TPO agonists, rituximab, or sometimes splenectomy.
And while it can be chronic in adults, the prognosis is generally good with proper care and monitoring. The main complication is bleeding, plus potential treatment side effects.
You know, when you think about all those differential diagnoses, all the different things that can mess with platelet counts,
Yeah,
it really makes you appreciate how complex our body systems are, doesn't it?
it really does. That delicate balance the immune system normally maintains, and what happens when it goes slightly awry. It makes you wonder about other autoimmune conditions too. What other self-components could potentially become targets?
Definitely food for thought. Well, that wraps up our deep dive on ITP. If you're revising for the MSRA and found this useful, do check out passmsra.com for more resources.
And there's also freemsra.com, another great site for MSRA preparation materials. Thanks for tuning in, everyone.
Until next time.